Hello, everybody. As we're starting to join the session, it's Jo Mitchell speaking. I'm facilitating the session today, but while you're waiting, can I invite you to go to the slide. Our event number there is on the front slide. And if you could enter into the poll, the traditional lands that you're joining from, and that will form part of our acknowledgement of country. Well, the 2 minutes passed. We've got 55 people on board, so I think we might get started. So welcome, everybody. As I mentioned, my name is Jo Mitchell, and I have the great pleasure of being the facilitator for this session today, which is around knowledge mobilisation and evidence support systems. And I'm sure you're all looking forward to the presentations from our three keynote speakers. As we begin the session today, I would like to start by acknowledging the traditional owners of the land. I am joining from Gadigal land, which is part of the Eora Nation, which is in the Sydney Basin. I think it's a really interesting time to reflect on, the importance of doing an acknowledgement to country. And, as a country, I think that we're seeing, great strides in terms of being more open to opportunities for reconciliation, but also there's a lot of discussion at the moment in relation to a voice to Parliament, which I think is a really positive step. And so what I would like to do as we get started is to stop sharing this screen and then have a look at, as you enter the places that you're joining from, a visual map of the many varied lands that form part of Aboriginal Australia. So I'll just change my slides, if you bear with me. And I will share now our map. And so I'm hoping that what has happened is that while people have been waiting, that there's been a great opportunity to actually see, oh, that's not the right one, I apologise, the way in which the different places. So you can see there now that there's a lot of people who are joining from Gadigal land, which is where I'm from. I can see Guringai. I know that's in the Northern Beaches because that's where I grew up. Similarly, I can see Ngunnawal land, and that's where I was born in Canberra. Ku-ring-gai and Awabakal, which I believe is up in the up near the Newcastle area. Bundjalung, I don't know. And Wungal, I think, is more in the eastern suburbs, but please use the chat to forgive me, and forgive me if I'm not quite right. But I think one of the nice things about doing this and seeing is that we become much more familiar with those different lands. So that'll continue to develop, and maybe at the end we'll come back to that as a way of just seeing how dispersed we are today. So it is a virtual workshop, and we are joining from many parts of the country. So thank you for doing that and continuing to do that. And I will now go back to the main slides and start the session in relation to the forum itself. So thank you for helping me to do that. So I'll go back to the slides now. So today the focus is on evidence support systems, and the objectives of the session today is to consider together the challenges of how to use evidence to address societal changes and where we are in Australia now and what we might need to do differently in the future. And I think one of the things that would be really great for people to think about as we go through the presentations are the sorts of questions that we can discuss as a group in response to the presentations, but also coming back to these as the key objectives. So a few quick housekeeping issues. So we've got the introduction to the symposium, which is happening now. Then we're going to have three presenters, Professor John Lavis, then Associate Professor Sarah Thackway and Professor Jonathan Craig. Each of them will give a different perspective on the issue at hand. So John Lavis will be talking about evidence from a global perspective. Sarah will be talking about evidence support systems within a state context, and Jonathan will talk about applying evidence and translation in a particular clinical content area, and then we'll come together as a whole. So although we'll have discussion at the end, we'll also have an opportunity for clarification questions after each presenter, but we'll save main discussion until the end. So a couple of housekeeping issues. So if you could please keep your video off and microphone muted. We'll also, just to be clear that although we do have Slido, we're using the chat function in Teams to ask questions, and we will be recording the symposium. The other thing, to ensure that there's plenty of time for discussion, about a minute out for each of the speakers' allocated time, I will ring a little bell so that we can preserve enough time at the end for discussion. So I think I will now introduce our first speaker, and I'll stop sharing so that Jonathan can share his own. And so our first speaker is John Lavis, and Professor Lavis is the founder and director of McMaster Health Forum. That's an organisation that aims to generate action on pressing health system issues of our time based on the best available evidence and systematically elicit citizen values, stakeholder insights. He's co-lead of the Global Commission on Evidence to address societal challenges, the COVID-19 Evidence Network to support decision-making and rapid improvement support exchange. So John's presentation will focus on the Global Commission on Evidence report, which was released earlier in the year. So John, I invite you to start your presentation.
Great. Thanks very much, Joe. I'm delighted to be joining you virtually. This is one of the only days in the year when I would actually prefer to be in Canada. I didn't have to chip through the ice to get to the water for a swim this evening, which was great. I'm going to do this presentation with humility because a lot of the leadership in this space happens in Australia. We've learned a lot from our colleagues there, and we'll learn more, I think, from Sarah and Jonathan today. But we hopefully do have some thinking that may be helpful, questions about which are the pieces in Australia that are going really well with supporting evidence and where might be the next priorities in terms of gaps that could be filled. The impetus for the Evidence Commission came from what at the time was 12 months, now is 27 months, I should have written, months of supporting decision-making about COVID-19 across all aspects of the response. We brought together back in April of 2020 more than 55 global partners, a number of whom were drawn from Australia, to figure out how do we improve coordination and reduce duplication in the evidence response to COVID-19. Two of COVID's achievements, one set had to do with ultra rapid and living evidence syntheses. Some of those were contextualized to the Canadian context. Others were global public goods. Living evidence profiles on topics like long-term care crisis management, vaccine rollout, COVID lessons learned. Those were contextualized to Canada. Other examples of global public goods, like 3 living evidence syntheses that we update now bi-weekly, initially weekly. This is real world evidence focused on adults, separately children and adolescents, and separately again, waning immunity. We also maintained the COVID inventory of evidence syntheses to improve the signal to noise ratio. So we, for every COVID-19 decision, identified the best evidence synthesis or syntheses for that decision based on 3 criteria: quality of the synthesis, recency of the search, and availability of a grade evidence profile. And that allows us to go from well over 13,000 syntheses to just over 650. Our biggest legacy, though, we hope, is the Evidence Commission report that we hope across all societal challenges, not just health challenges, provide the context, concepts, and vocabulary to underpin work in this area, but also provide recommendations about how we can and we think must improve the use of evidence, both in routine times and in future global crises. And the report is available in 7 different languages and in a variety of formats. You'll recognize 2 Australians in this slide. In the first column, Julian Elliott. In the second column, Andrew Lee. Julian bringing a professional perspective, Andrew a government policy perspective. But our commissioners covered all types of societal challenges, educational performance, climate action, you name it. All types of decision makers, in addition to the 2 I mentioned, also organizational leaders and citizens, all forms of evidence, and all world regions. And we learned an incredible amount from these people, including our commissioner in the top right, a young Indigenous leader from the Brazilian Amazon who wrote a very important section related to Indigenous ways of knowing. We've tried to get the key messages from the report out in a variety of different formats. It's been covered in Nature, in a guest essay in the New York Times, and in a number of other publications. We typically, when we present to decision makers, introduce 2 slides, which from our perspective provide the burning platform to, again, systematize and scale up what's going well, but also to address the gaps. And the first part of that is we can't allow a low signal to noise ratio to again be the hallmark of an evidence response to a societal challenge like COVID-19. Uneven coverage, you'll see in this slide, very few syntheses about economic and social responses, very many about clinical management. Unfortunately, many low quality syntheses in light blue. Roughly 1 in 4 syntheses were of low quality. In gold, roughly 1/2 were only of medium quality. And many syntheses became outdated very, very quickly. The world would have been much better off had we invested in a suite of high quality living evidence syntheses. Instead, we had tremendous amounts of research waste, both in the evidence synthesis space, but also in primary research. The second part of the argument for, again, celebrating and scaling up what's going well and addressing gaps is we can't continue to respond to policymaker questions with preprints that haven't been appraised for quality and put alongside other studies addressing the same question. We can't continue to rely on squeaky wheel experts who can't clearly specify how they identified, appraised, and synthesized the evidence on which they're drawing. And we can't continue to rely on old school expert panels that don't bring people with content expertise, methods expertise, and lived experience to the table, supported by evidence, and encouraged to be transparent about how their recommendations are based on best evidence. That's the left part of this slide. The other thing that we can't continue to do is rely on select forms of evidence instead of the right mix of evidence. So we saw a lot of excellent use of data analytics, modeling, and one-off evaluation studies, but in many countries in the world, a remarkable underuse of behavioral and implementation research, of qualitative insights, including how racialized communities, Indigenous peoples, and others were experiencing challenges and responding to potential solutions, and high-quality evidence syntheses and guidelines. The most important recommendation, which is what I'm primarily focused on in this presentation, is the recommendation from the Evidence Commission to formalize and strengthen what the Evidence Commission report calls evidence support systems. Australia, like Canada, like many other countries, has for many, many decades had a robust research system. We have also had robust innovation systems. The piece that often has never been formalized and care has not been taken to strengthen has been what we call the evidence support system, a system grounded in an understanding of a national context, or in the case of New South Wales, a state context, including the time constraints that decision makers are working under. It's demand-driven. It's focused on contextualizing the evidence for a given decision in an equity-sensitive way, often in hours and days, and certainly not the months and years that often are involved in primary research. 4 examples of infrastructure here. evidence support units that can combine the power of national or state evidence and the power of global evidence, expert panels that include people with methods expertise and lived experience, that pre-circulate evidence summaries, and that clarify what evidence and experience underpin the recommendations. We looked with great envy at the Australia Living Guidelines focused on clinical management. We wish we had had similar processes in Canada for clinical management, but for also all of the other expert panels that we had addressing public health measures, health system arrangements, and economic and social responses. We also need to provide ways in for evidence to other citizen and stakeholder engagement processes. Third example of infrastructure, government science advisors who speak in a way that make it possible to judge their accuracy. One of the challenges with COVID-19 was so many talking heads, and it was very, very difficult for many of us to determine how much was personal opinion and how much was based on a robust assessment of the quality and local applicability of the evidence. We also need processes to elicit and prioritize evidence needs, find and package evidence that meets needs within the set time constraints, but also, as you'll hear Sarah talk about, build additional evidence as part of ongoing evaluations. We also need to build capacity. My old colleague Jonathan Lavis would call it receptor capacity to use evidence. And we need to figure out, how do we incorporate evidence into routine processes, submissions to cabinet, budget proposals that go to the Ministry of Finance, spending plans that go to, in the Canadian case, Treasury Board Secretariat. Some of the other points about evidence support systems are they need to match the form of evidence to the right step in the decision-making process. So in the last couple of years, big focus on big data, data analytics, very, very helpful to understand the problem and its causes, very helpful in monitoring and evaluation. But we need other forms of evidence like behavioral and implementation research when it comes to questions about how do we reach and actually make a difference in the lives of the many diverse communities that we serve. Another point about evidence support systems, something long known in Australia, of course, is that combined power of local evidence. So what has been learned in Australia, or as Sarah will be talking about, specifically New South Wales, but also what does the best global evidence from around the world say? And so what have we learned from around the world, and how does it vary by groups and contexts? And you'll be hearing from Jonathan about contributions they've made to these evidence-related global public goods, to the core outcome sets that should be driving trials, and so on. And we need that combination of the two. And when we think of that national or state evidence, you'll see those 5 forms of evidence that we think of as essential. Then you'll see the global evidence, and often they're then combined and through expert panel processes turned into recommendations, either in the form of technology assessments or guidelines. Australia is widely known as the global leader in living evidence, and this has been the area that we've just seen such a dramatic scale up of efforts. And this ability to slot the new science into an evolving understanding of what we know based on the quality of those new studies is a real game changer in the world of policymaking and decision-making more generally. And we now recognize that these living evidence syntheses can be both the global public goods that Julian and others have championed, but we can also have demand-driven, contextualized, equity-sensitive syntheses dealing with things like vaccine rollout, adjusted week to week during those urgent days when we were trying to get as many people vaccinated as possible. The final general slide about the evidence support system is we need the right strategies to support the use of best evidence for the right issues and context. You're going to hear shortly from Jonathan, who is a real leader in consumer engagement in the research process, and that co-production or co-creation that we talk about in the second row here, absolutely essential to create new local evidence. We had a citizen partner working with us in COVID and for the Canadian arm of the work And she maintained a panel of 20 citizens from all walks of life, diverse socioeconomic status, different regions of the country, different racialized communities. And they were willing to put their hand up within hours to jump onto a team to contribute to a rapid evidence process. And that's the type of co-production we need to see more of in the future. But we also need government science advisors who speak in a way that make it possible to judge their accuracy. We need to start combine what had been silos, evidence going in, data analytics going in, evidence syntheses going in, all separately into decision makers. And we need to figure out how do we combine those different forms of evidence in very timely ways that are demand-driven, contextualized, and again, equity-focused. We also need to always know what the best one-stop shops are in our areas. If it's COVID-19, it may be the COVID end inventory. If it's how do we strengthen the health system, it may be health systems evidence. If it's how do we address climate change, it may be the evidence map maintained by Jan Minks and his colleagues using machine learning. And these living approaches that Australians have pioneered, we're now starting to apply in the policy world with living citizen panels and living stakeholder dialogues. The next step for us as the Evidence Commission Secretariat is to partner with teams currently in 20 different countries around the globe, one of which is Australia. In fact, we have a call tomorrow night with Greg Johnson and colleagues to talk about the Australia Rapid Jurisdictional Assessment. This just gives you a feel for what we found from the Canadian Rapid Jurisdictional Assessment when we looked at the federal government. So some things going very well. We have standards and procedures for 3 forms of evidence: data analytics, evaluation, and cost-benefit analysis. But we don't routinize the use of evidence in regular decision-making processes. So with our Privy Council office, it's not a requirement in cabinet submissions or for commissions of inquiry. With our finance department, evidence use is not a requirement in budget proposals. With Treasury Board Secretariat, evidence use is not a requirement in spending submissions. And while it's great that we have procedures for 3 forms of evidence, if we had to pick from the other 5, we think the next critical priority for the Government of Canada is standards and procedures for evidence synthesis. But finance could help us with modeling. They could tweak their requirements for cost-benefit analysis to make sure evidence syntheses are used in the benefit part. And while we have procedures for evaluation from Treasury Board, they're a very old school model based on fixed policy and program objectives, 5-year evaluation cycles. They don't support evidence-driven learning and improvement like we need to be thinking about. And the public service, alongside its many existing skills, needs skill in finding and using evidence. And when we come to our Science and Technology Ministry, they seem uniquely well positioned to establish standards for government science advice and for expert panels. And when we come to what we think of as line departments, like the Ministry of Health, and you'll soon be hearing from Sarah, which New South Wales seems to be firing on all cylinders in many domains. Our federal government departments, including the health ministry, have real opportunities to up their game. They have no process currently to prioritize their evidence needs and commission evidence. They can't point to the one-stop shops of pre-appraised evidence that their staff should know about and use. It's not obvious from the outside that their science advisors are trained in evidence support, and certainly having looked at the 17 expert panels that they supported for COVID-19, that they follow standards for high quality expert panels. So lots of opportunities to up our game, including through some of the parliamentary parts of our system, like the Auditor General. So this is an example of us doing a rapid jurisdictional scan for one jurisdiction, the Government of Canada, celebrating the many successes, but also talking about, of all of the things that we could do to improve the evidence support system for a federal government, what would be the priorities and who needs to take action. And you'll see, we think that's the responsibility of central agencies, our Science and Technology Ministry, and line departments. I don't have time to talk about it, but you're going to hear from Jonathan again about some of the superb production of evidence-related global public goods that he and others in Australia are contributing to, and that's my second to last bullet. But we also need to push the UN system to up their game. In the Evidence Commission report, we celebrate some of the successes of WHO and UNICEF, but they need to scale up and out many of their excellent processes that they put in place for COVID-19 to many other societal challenges. But most other UN system entities aren't at that level. And they, we believe, need to move away from an expert knows best model for normative guidance and technical assistance, and away from an underinvestment in evidence-related global public goods like Cochrane reviews. UN's Quintet of Change, we think, needs to be updated to include other forms of evidence. The UN Secretary General's Scientific Advisory Board shouldn't use an old school GOBSAT model, good old boys sitting around the table. It should rise to the highest standards of expert panels around the globe. And we need funders to step up and make the necessary investments. The final priority, also for another day, because my main focus today is evidence support systems, but we also need to think about a future where evidence is at the center of everyday life. And we shouldn't be finger wagging at citizens, encouraging them to develop their health literacy, their digital literacy, their information literacy. We should be thinking about how we build evidence into everyday life. And you'll see a number of examples here about groups or initiatives that have the power to do that. So my final slide is why now? I've worked in this field for 25 years. This to me is the best chance we have ever had to dramatically up our game. We have a cadre of political leaders who have direct experience with being well served in many circumstances, poorly served in some others. These rapid jurisdictional assessments will help us celebrate what's going well, but also prioritize gaps. And as you've heard me say, we can't just focus on health. We need to look at the central agencies. We need to build evidence into routine processes, and we need to set standards and procedures for all forms of evidence, not just a few. We need to capitalize on these innovations that Australia has been at the vanguard of. We need to act on the lessons learned about needing to have these supports in place to pivot to future crises. The COVID-19 evidence investments shouldn't just come to an end, they should be redirected. And we have so many challenges ahead where best evidence is needed. So now, to me, is the time where we need to, again, celebrate the successes and really focus on filling the gaps. So Joe, I think I came in right at time. I'll turn it back to you and look forward to the discussion.
Terrific. Thank you so much, John. That's perfect timing. And I've just put into the chat that if there are any clarification questions, now's an opportunity to put them into the chat. I think just sort of on reflection, that was a really wonderful presentation, which sort of covered so many things, some of which I think for the audience will be not a surprise, but other things are, quite new and different as well. So I was sort of really struck by, your earlier comments around, that where some of the gaps in the evidence were, and some of those patterns I think are, quite similar to patterns that we've seen before in terms of, less focus on implementation science, for example, less focus on economic evidence. And I like the way that you link that back to the concept of research waste. And in this kind of an environment, that's really important. Some of the bigger ideas we'll come back to in the discussion, I'm sure. So there's no clarification question. So I'll now introduce Sarah Thackway. Sarah is the Executive Director of Epidemiology and Evidence at New South Wales Health, and she's a Conjoint Associate Professor at the University of New South Wales School of Public Health and Community Medicine. She has more than 25 years' experience in public health across policy, frontline and research sectors. Her interests include cross-agency data linkage, systems development to measure the effective rollout of interventions, and supporting innovative ways to improve the use of research in policy process. As you can see from her slide, Sarah's going to talk about how the evidence support system in New South Wales has been a really important part of the support for the response during the pandemic. So over to you, Sarah.
Thank you, Jo, and thanks, John, and thanks to the Sax Institute for inviting me. I think this is a great session. I'd like to start by acknowledging the Gadigal people on the land of which I am today, and thank them for looking after this land for thousands upon thousands of years. I also pay my respects to elders past, present, and emerging, and anyone joining us here today. So thank you. I also acknowledge this land was never ceded. So look, John, that was a fantastic presentation, and I found it really useful. I think, thank you for your comments about Australia. I think there's still plenty more to do, but let's hope that also the value that we've seen from the COVID experience means that we can continue to invest in this space. Look, I'm going to provide a few caveats here, because what I'm going to be talking about is how we've built a research-ready environment in population health over, I was thinking this morning, it's actually more like 25 years. And this really is only part of the health system. There's plenty else that's happening in the clinical and medical space, and also in certain disease-specific areas like cancer and cardiovascular disease. So really I'm focusing on the prevention space, but it shows the breadth of effort across the health system. So look, as we mentioned, that we believe it's important to generate the right research evidence, and right can be obviously interpreted in many ways. And for us, that's the research evidence that can be directly applied to our policies and practice to actually deliver the best services to the people of New South Wales. I'll come in a bit more detail in the next slide, but we do this by competitive funding schemes across the research spectrum, funding priority research. Also, it's acknowledging that we run evidence-based programs across the state every day, and so we build our own evidence every day. So it's important to work with our academic partners to actually harvest the evidence from that and do the evaluation to see what's working. We also strongly support New South Wales Health staff having conjoint appointments. You'll see that I have one as well, but most of the staff that I work with do have that, and I think that's an important connection. And it is about those long-standing relationships and trust and partnerships that I'll talk about again later. But then once you also have the right evidence, it's also got to be mobilised. And a great example of evidence syntheses, and I think that was given by John, and we've seen that change so much over the years from the more passive ones to the very active living syntheses that's made a difference in COVID. But also bridging the gap between health decision makers and researchers, like we're doing today, hopefully. Data assets, research assets, capacity building and accountability. So it's trying to look at a whole range of different aspects and to treat this like a portfolio. But also from a government perspective, we see evidence as an ecosystem. It's not just the research evidence that comes from, say, the basic science or the health and medical research literature, very important part, but it's also, as I said, it's the ones that we create together with our academic partners. It comes from our program and service evaluation. It comes from the PROMs and PREMs, the patient-reported outcome measures that we create, and through our data quality assurances. And so it's looking at a whole range of evidence, and when we're talking about how we invest. This is another way of describing this portfolio investment that we do in terms of the pipeline. And so, we talk about the assets, huge amount of data assets, which are very useful, but it does have to be built on with other sort of more qualitative research as well. And we do some of that work with the priority research centres, and that's not a transactional relationship. That is a true partnership with co-produced research. And I'll acknowledge Jo Mitchell for her great work in establishing those concepts of particularly the BREEZE concept, and really looking at doing research differently between researchers and the policy funders. We have a range of competitive funding schemes. I particularly want to call out the PRISP, the Prevention Research support program, because I'll come back to that later, because that's about funding, long-term funding, about 20 years of funding of infrastructure to academic institutes. It's not for a particular research program, it's the infrastructure concept. Then we also support collaborative research like the Preventive Partnership Centres. We're chief investigators with our academic partners on a whole range of NHMRC grants as well. But we also then support other areas of research and evaluation. Strong supporter of the Sax Institute for, I can't remember, I think again it's about 20 years, and we commission evaluations. But as John talked about, the importance of receptor capacity, about the ability of the health system to actually understand and uptake that research is just as important as all of those investments. Like if you create the best research evidence, that's great, but if it's not used, then it perhaps is waste. So we spend a fair bit of time in building the capability of the health system in the preventive space to undertake research and critically appraise evidence that is in the published domain. And there are hundreds of people who attend the training every year, whether that be online, face-to-face, or our study guides that are also online, an important part. And we also have our training programs, which I referred to on the previous slide, which has trained hundreds of public health and biostatistical trainees, and part of their training does include evidence. So that's a very quick run through, and I haven't really talked a lot about the data space either. But I wanted to focus a little bit more on how then we were able to rely or reference back and work with those people that I've talked about in those previous slides to support the response to COVID-19 in New South Wales. And we were doing this by applying existing processes, relationships, trust, to generate new local evidence that was directly applicable. So I'm going to focus on, I'll quickly mention the bottom one, which was like to just acknowledge the Office of Health and Medical Research in their work in expediting processes. So research ethics approvals, you know, the timeframe for approvals was significantly reduced. So reducing red tapes and barriers and making the research easier. Supporting clinical trials initiatives and industry schemes, which are out of scope for my presentation, but a huge amount of effort went into that. I just wanted to acknowledge and call that out. In the top left of this circle, you'll see a couple of things that we did in terms of research grants. So there was a competitive research grant scheme, which was able to be applied using existing processes that were tweaked, and that included the court expression, the reviews, and when we did the reviews, that included practitioners, not just researchers, looking at the actual implementation aspects of those competitive grant schemes. So that was using existing, once you had the announcement, very quickly following the political announcement, we were able to launch that scheme. The second one was the Emergency Response Priority Scheme, which was really supporting the Chief Health Officer and the people on the front line of the response. And that was engaging on a day-to-day basis with our key research partners to develop knowledge that was directly linked to action. And the way we did that was because we had those long-standing relationships, because we funded infrastructure, we were able to call on a number of our colleagues, and actually thanks to them, and some of them will be online today, they called us and said, how can we help? So one of the examples I just wanted to call out was very early on, so in the pandemic. So it was relating to the local evidence around COVID transmission in New South Wales schools. And so this was, you know, I think really it was called a global pandemic in March. This study happened by Ncds in collaboration with people in our public health response branch who actually went into schools and worked with the Department of Education and found little transmission of that variant of COVID-19 among children, and none actually of children affecting teachers. It was all being brought in. And that evidence was really useful. And so by the time pandemic in March, research in April, it informed the decision of New South Wales government to reopen schools in May. And you can see at the bottom there, it informed the public health order that directly made the decision and provided an evidence-based decision for the Chief Health Officer and for government to make. Also, the researchers at Ncds then published that in Lancet, being able to provide that evidence more globally. So it was a really nice, and look how quickly that happened. And it was only able to happen because we had those evidence support systems in place and those trusted relationships. And there's many other examples. I've done another one there with the Kirby, but I won't go into that because a lot of that was captured in a research impact evaluation that we undertook within my branch. And there is a link at the bottom there, and I would recommend that you have a read of that. But it sort of looked at the impact of that rapid process. And I just want to quote Dr. Kerry Chand, who most of you probably know quite well by now, which is about the research happened seamlessly. It didn't add burden, like we were being smashed at the public health response side, but the research didn't add burden on either side. The researchers were nimble, were able to come in, work with us directly within those environments. We saw them as part of the team, and they were being able, because of some of the public health changes, we gave access, and they were doing work directly for us, access to data. It was efficient, and it was evidence-based. So it was a fantastic new way of working with researchers, and I would also comment that we hope that this would be able to continue. So moving on to another thing that we did, I mentioned the Prevention Research Support Program, long-standing infrastructure support program. So we were flexible with the guidelines on how the funding could be used, gave a one-year extension, and we did an assessment of how that was used. And basically, all of the funded organisations contributed to the COVID response in many ways, whether that's critical research functions or leadership roles. SIDM were really important in enhanced genomic tracking of COVID importations, transmissions, and even mutations. And the Kirby worked with us on a range of research activities as well. And also providing staff to the front line, which I will mention again in a little bit later. Sorry, I'll just have a little glass of water. One thing I also don't mention is that we did provide a lot of data, made a lot of data publicly available for use by a range of people. And I think we were the first to do that. And I think that was really useful for us because we found great entrepreneurs mapping that. And it meant that we didn't have to do that, provide maps of where the venues were and all of that. It happened organically by releasing the data and information. I'd like to acknowledge the ACI, who set up the Critical Intelligence Unit on behalf of the Secretary. And one of the activities of many that they did was set up a living evidence base. And this website's still live. The evidence checks and the dashboard, the digests are all still there. And it's a fantastic resource to be able to rapidly access international evidence in a way that was useful for New South Wales Health. The digest or the newsletters came out every day to the senior health system, and it was a fantastic way of being able to easily access information because the information and research evidence was coming rapidly from around the world. And just my final slide here, because there's a lot behind this. I said it's a very rapid romp through all of this, is that we did do a range of other support activities. We had external panels, but they did include, they weren't, I like your term, John, gobs or something. I might use that one. But these included practitioners, clinicians, and academics, and provided a really, and they were rapid, they happened really quickly, and was able to really be able to access a wide range of evidence that we wouldn't be able to access if we just either got the gobs together or did it internally. So it was really useful by having that broad mix of people. A clinical council was established again by the ACI and communities of practice across a whole range of networks. The Health Protection Network met at least multiple times a day, and they were the frontline responders in the public health network. A modelling science table was established by Andrew Malat, and the reason why this was established was as we started releasing lots of data, a load of academics, which was great, started doing modelling. And so it was getting in the media, and we were being sort of bombarded by the media by saying, what do you think of this? And actually, we wanted to know, well, what was the best model? How could we use it to actually look for bed capacity, ICU capacity, staffing capacity? And perhaps this is useful. We didn't have the internal capacity to do it ourselves, but everyone was doing a different modelling. So the modelling science table brought together the main players in this space from the academic sector and turned it into a really useful framework that looked at the different models, looked at the caveats, strengths and weaknesses, and extracted from that what we probably needed to know as a health system, and did it in a coordinated and collaborative way with all of the researchers. And that's still ongoing, and it was a really useful mechanism. Secondment of academic staff. If you're online, thank you. Because this wasn't in the research space, but the University of New South Wales was the first one to come to us and said, how can we help? Our research has stopped. We want to come and join the front line, but we can also bring with us our academic approach to that. And so we wouldn't have been able to do the response without the support that we had from the academic sector in the non-research capacity as well. But it was also thanks to our relationships. We also set up governance, whether that be the strategic research governance group to look at those two types of research I was talking about before. And there's also a research intelligence group with researchers and clinicians that's a lot more broader. So it's been incredibly active space. It's been a hugely productive 2 years from a research side. I was talking to other Canadian colleagues who was talking about that the academic publications around COVID that have come out of Australia and New South Wales are really high. And we're punching above our weight in that space. And I strongly believe it's because we've invested in the evidence support systems. And just on a personal note, it's incredibly rewarding to see that response and the value of our investment and the strategic approach that we've taken coming to fruition in such a critical time. So that's really just a touch the surface, but thanks, Joe, for that.
Terrific. Thanks, Sarah. And what a wonderful run through some of the approaches taken by New South Wales Health. And I think that the important thing that you say there too is that it's not just about the COVID response. It was, in fact, the 25, 30 years of investment and yes. Development over many years. So it's like people say, you're an overnight sensation, but people don't see all of the steps that are put in place to enable that to happen. So for me, you know, some of the things that really sort of resonate for me is that sort of sense of it is the existing processes, having the existing processes in place, but the value of relationships and trusting relationships between policymakers and researchers is really the enabler to allow such a rapid response to happen, it would seem to me. I notice in the chat that John has reminded us that GOBSAT stands for Good Old Boys Sitting Around the Table. And also we have Amanda has put a link into the New South Wales COVID research program impact evaluation report. So if you're interested in having a look at that, that's you can look at that in the chat. We've had one question so far, which I think we'll reserve for the discussion, and that comes from Kate White. So just to encourage people to be starting to think about the questions for our discussion and start putting them into the chat so that I can facilitate more discussion amongst the panelists in response to the things that interest you, but also going back to our objectives for today. Part of that's also thinking about, well, what does this all mean for us in Australia, and what are the next steps in terms of how we continue to build, take advantage of COVID as a way to build and go to the next level, I suppose, in terms of evidence systems for evidence. So I'll now introduce Jonathan Craig. So Jonathan is the Vice President and Executive Dean at the College of Medicine and Public Health at Flinders University. He's made a significant contribution to the clinical research landscape in the prevention, identification, and treatment of chronic kidney disease. He's led the formulation of state, national and international networks to conduct high-quality trials and has been instrumental to the development and implementation of best practice methods and guidelines. So Jonathan's going to talk about better and equitable evidence translation for people with chronic disease. And so I invite you, Jonathan, to begin your presentation.
Great. Thank you, Jo. And firstly, I have to say, I feel a little bit of a fraud having heard from John and Sarah. I mean, just really, I'm sure people on the call would just be impressed with the quality of the work that's happening and the values driven and the public good element to that. So with that caveat, yes, thanks, Jo, and thanks, Sax, for the opportunity to invite. And my focus is really around one clinical area, and I hope that some of the learnings from that area might be broadly applicable. Firstly, I just want to acknowledge the countless patients, caregivers, clinical research colleagues who've generously imparted their wisdom on their lived experience and how research can be truly transformational with people with chronic kidney disease. And I see that many of those colleagues and indeed caregivers on the call. And I'd also like to acknowledge NHMRC is on the call, and I think your leadership, particularly in the area of consumer engagement and privileging the consumer voice, has been and will be so critical. I too would like to acknowledge the traditional owners here in Adelaide, in the Adelaide Plains. I'd like to acknowledge the Kaurna people and note that Flinders works across the traditional lands of very many people, and I'd like to acknowledge all Aboriginal and or Torres Strait Islander people on the call. So this is my proposed outline. I'm going to talk a little bit about the epidemiology and impact of chronic kidney disease, a little bit about the evidence ecosystem, and then opportunities and challenges into the future. So firstly, it's important to understand a little bit about chronic kidney disease. This is from ANZ data. We're very lucky, as we'll see in Australia, that we have a complete and comprehensive register of all people who have been dialysed or transplanted. There's really three groups of people. There are those who've got early pre-dialysis chronic kidney disease, which is about 10% of Australians. We have around 15,000 people who are on dialysis. They might be on two forms, hemodialysis, so you're connected to a machine 3 times a week for up to 5 hours, or peritoneal dialysis, when there's a tube that goes inside you and you're typically dialysed at home. There's around 13,000 people who have received a kidney transplant. Every year there's around 3,000 people start dialysis, but as people may be aware, there's not enough kidneys to go around, particularly in the COVID-related area where we see a dramatic fall in suitable kidneys. So that's it by the numbers, but perhaps more importantly than the numbers is the experience. So people on dialysis, their mortality rate is around 15% per year. So if you're in a hemodialysis centre in a hospital, you will start to see chairs that used to have people in them, and then people stop coming as they unfortunately pass away. Dialysis is a pretty unpleasant procedure. It is life-saving, but to be dialysed where effectively you just have the fluid and waste taken out of you 3 times a week to 45 hours leaves people incredibly washed out. There isn't cure, it's management. There's also profound social impacts, not only on the person directly affected, but also on the caregivers and family members. Like any chronic disease, there's massive uncertainty. It's a life of complications and hospitalizations, and typically there are utility values of 0.6, which means that people would forego on a scale of 0 to 10, so they would forgo a substantial element their life, of their current life, to feel in perfect health. One of the most profound experiences I've had is listening, particularly to children express. This is me in the background trying to keep my tears from welling up. This was a symposium where we had some of the world-leading pediatric nephrologists in the audience, but also we had children who are engaged in describing the impact of chronic kidney disease on them and their families. And to be honest, they probably were the most articulate of anyone in the room. Being alive is important. Most of us don't like it. That's the chronic kidney disease. It's sad. You've got to experience surgery, doctors, and other medical related things. You have to experience pain. Most of us feel worried, scared. Life participation is most important, because without it, you can't do anything. As we'll see, pretty much if we start to give the microphone to consumers, to patients, to caregivers, we start to align the evidence and evidence systems along the lines of what actually the end users should be receiving. So it's old, but in 1971, Julian Tudor Hart published what was, I think, one of the most critical pieces ever, and he coined the term the inverse care law. And it's very simple, which is the availability of good medical care tends to vary inversely with the need for it in the population served. That is, the people who most need something are often the ones least able to receive it. And we saw this certainly through COVID, where the impact was not homogeneous, but it was patchy, and it had the greatest impact upon the most disadvantaged. And CKD is like that. It's like other chronic conditions. It is a disease of inequity. Some groups are more likely to get chronic kidney disease and progress faster. They're less likely to receive appropriate care, and they're less likely to be engaged in transformative research. So that is that some people, most disadvantaged, are more likely to engage in research and directly and indirectly benefit from research. And we also have orphans, essentially research orphans of the most disadvantaged who participate least. In chronic kidney disease, as in many chronic illnesses, this is First Nations people. There you've got some statistics which show about the risk of kidney failure being higher, and also the likelihood of receiving a transplant is substantially lower. Those in rural and remote settings, and I think Jenny May is on the call and should be well aware of this. Unfortunately, people in rural and remote settings are much less likely to receive specialist care, out-of-pocket expenses, and experience higher mortality and hospitalisation. The economic impacts are substantial. They have accommodation costs, they have transportation costs. And then sadly also for women who are generous, they're 2.5 times more likely to be a living kidney donor, but they're also disadvantaged because they've got half the likelihood of receiving a kidney. So that's chronic kidney disease in very broad overview systems. In Australia, we're incredibly lucky to have an evidence ecosystem which captures all of the major bases, and you would have seen an ecosystem model that Sarah's provided. We have a kidney trials network, which is national, international links. There's about 11 trials that have been conducted and another 8 or 9 at present. We've got the Cochrane Kidney and Transplant. People would be aware of what Cochrane does. We have national guidelines to do with chronic kidney disease, and we have a complete comprehensive register of all people who've received dialysis and transplant. So putting this together, we've really got an opportunity to evaluate how things are going with existing quality of care in trials, to evaluate promising interventions, to synthesize existing evidence through Cochrane, and implement that globally, and then turn reviews into living evidence in the form of guidelines and evaluate how we're doing. So this is, we have this ecosystem, and it's all around ensuring that everybody in Australia, and indeed hopefully globally, lives well with their chronic kidney disease. How have we gone in terms of integrating what historically have been kind of siloed evidence support systems? Well, we have some of the integrations been more effective than others. The link between the registry and the trials network, we have registry trials, an example of best fluids. We've got updated guidelines such that a new trial is published, can be integrated more or less in real time with current guidelines, so that we've got the totality of the evidence. Systematic reviews do inform existing trials, such they build on, don't compete and don't duplicate with other trials. We've got living guidelines in the area of diabetes and cardiovascular disease, but there are a couple of areas, particularly in relation to closing the loop and evaluating the quality of care routinely delivered, we perhaps could do better. What about opportunities and challenges? So one of the issues is that typically the evidence systems are described in a linear pattern where evidence is produced, these are synthesized, and then these are applied. But in reality, it's a much more organic, multi-directional element where we're seeking to improve the quality of evidence as well as improve the quality of the evidence systems. And in this, I think in kidney disease, the consumer voice has been the glue, which have really been the common voice across all of these platforms. And I say the fix because historically in CKD, as in other areas, really the research agenda has not really aligned with that which is most important for consumers. And this has been expressed in a couple of ways. One is around shared membership advisory groups across all those four platforms. And I'll talk very briefly, if I'm able, about standardized outcomes in nephrology. So John talked a little bit about some of the problems with existing evidence. The other issue is that trials are really only as good as their outcomes. And what we see as an example in hemodialysis, that the outcomes reported really don't align with that which is relevant for both clinicians and patients. So, for example, we looked at a fairly large data set, 362 trials. 20% of trials reported quality, mortality, only 12% cardiovascular disease, and 9% quality of life. What we have is extreme heterogeneity. This is a snail plot or a radial plot of all of the outcomes domains reported in those trials. You can see a huge number of outcomes measured, very many of them surrogate, which may not be particularly relevant for patients or clinicians. Such as serum phosphate, and even for serum phosphate, there were not 139 different ways that phosphate was measured and reported in those trials. So if we're trying to synthesize and come up with a totality of evidence, the difficulty is this extreme heterogeneity and frankly irrelevance, which makes that somewhat problematic. This is important because if we look at the outcomes that are relevant to patients and are relevant to health professionals, and here's an example again on hemodialysis, and we see this across all the outcomes, that the things that matter, that there are some things that do matter equally, but there are some things that matter more to patients than health professionals, such as actually being off dialysis, whereas what we see for healthcare professionals, and this is pretty consistent, that death and mortality and hospitalization matters more to health professionals than it does by patients. So we need a mechanism of ensuring that research aligns with shared outcomes across both groups, which is why, yep, 1 minute.
Joe, I'm just giving you a time warning.
Great, thank you, understood. So the SONG initiative, what was sought to do is develop core outcomes across chronic kidney disease, which is a standardized outcome that should be measured and reported in all clinical trials, and this is relevant for everybody. What we've done is that we've rolled these out across hemodialysis and different sorts of chronic kidney disease. To date, we've engaged around 10,000 people worldwide, of whom around 5,000 are patients or caregivers, so that it is really possible. We also pivoted in April 2020 to develop core outcomes for COVID-19. So these are the core outcomes we've developed in hemodialysis, fatigue, cardiovascular disease, mortality and vascular access. And these are in the process of being implemented not only locally but also internationally. What are the next steps? Well, we need a systems dynamic model of care and not a fragmented model of care. There are strategies to improve transplantation for Aboriginal and Torres Strait Islander people, mechanisms to ensure that equity is addressed for core outcomes, the role of patient navigators to improve access, care and outcomes so critical. Dialysis, the question is, can we reduce the frequency and amount of dialysis to make it more amenable, particularly to those in rural and remote settings, and to bring that equity lens across all research. So hopefully I'll provide a bit of an overview of how these things could be addressed in a targeted or discipline specific, and thanks for your time.
Terrific. Thanks so much. That was just a really, again, a wonderful presentation which spanned a lot of areas, but clearly one of the areas which came out very, very strongly was around the importance of lived experience, and some of the work that you've done there too about the way in which you're able to get some broader agreement on the outcomes of interest are very fundamental, aren't they, in terms of being able to bring together researchers and the users of that research, both from a clinical and a clinical perspective, but also the recipients of that care. The other thing that strikes me too in terms of describing the CKD evidence ecosystem are those sort of 4 areas that you talked about. And some of these have already been raised by both John as well as Sarah about the importance of identifying and having priorities for research, evaluating things that are promising interventions, looking at the global synthesis, and then also looking at the issue around implementation and getting evidence into policy and practice, which is really the main theme of this as well. While the conversation's been happening, there's been I've tried to look at some of the themes that I think have come up across all of the presentations, and so it's a very quick assessment of that. But just before we go into questions, and there are several on the chat, I thought I'd try to summarise some of those themes that seem to cross the 3 presentations. So the first is really that sort of sense of that this work is values driven. From the 3 presentations, we've heard about, public good, we've heard about the consumer perspective, and we've also heard from Sarah around the professional satisfaction of doing this kind of work, which makes a difference. We've heard about how important the system is for being able to mobilise to be able to mobilise knowledge in an agile way. It's very hard to set those systems up on the run, and so that part of the success across the board has been around investing in those systems. There's been a discussion across each of the presentations around living evidence and syntheses, different types of evidence. And in terms of thinking about what all of this might mean going forward. I think that the focus on the rapid jurisdictional scan, what that highlighted for me as well is that we often think about sort of evidence in terms of within a Department of Health, within clinical practice, within intervention, but that sort of brings it up, to a higher policy level in terms of at a governmental level, and really embedding evidence in that sort of higher level decision making. So I'm now going to go to the questions that we've had, and the first comes from Kate White. As presenters, you'll be able to see this in the chat as well, and the audience can as well. So Kate asks, what are the strategies that could be or were implemented to engage with and include all disciplines in the clinical settings? And she makes the comment that one of the challenges working in the clinical setting wards was that when processes didn't work, there was no mechanism to provide feedback or contribute to the development of protocols, and that there was a limited opportunity to contribute to and shape the research. So perhaps I'm reading into this, that this is particularly around the COVID response. So I might sort of ask Sarah if you'd like to respond to Kate's comment and question.
Thanks, Joe. Look, I don't think I can really comment on this because I think, I'm not familiar particularly with the ward setting and the clinical response, but I think it is hard, and it was hard for a health system to have to change and take this evidence that was changing rapidly and apply it across the health sector quickly, as well as seeking feedback. So it was achieved, in my understanding, the best that it could by having the clinical councils that they had, the communities of practice that they had, which had strong engagements with the local health districts, probably not down to the setting, perhaps, Kate, that you're talking about there, but the level of engagement that happened across the LHDs with the ministry was a significant effort that was taken with the ACI and with the SHIOC teams. Also, there were, I think, I'm trying to think of how frequently, but it was a bit like the emergency cabinet. There was the equivalent within health set up with the chief executives to sort of try and understand what the health system challenges and needs were, and try and look at how we could engage and do things better across the system. So it's hard to fully answer that in an emergency setting. I think it's hard. I think that the benefit going forward would be would be for LHDs to work on those settings so that they're established already, so that come the next pandemic, because we know that there will be one, or other situations, that you're able to provide that feedback and contribution already in place, so then it can just be activated, because that's really the best way that we can do this, by setting things up. I think the system tried rapidly to set up and resolve those issues, but it was in such a time when they're also responding to so many other things. So as I said, there were those processes put in place with the clinicians and with the chief executives and with the operations managers and across the LHDs, perhaps not quite getting to the level of detail you're talking about, but still trying to find a way to translate the evidence and provide feedback.
Thanks, Sarah. And Jonathan and John, are there additional comments that you'd like to make in relation to that particular point?
So what I might say, Joe, and I think John alluded to this, is that the sad reality is that, and I don't want to diminish the impact of COVID-19, but the COVID-19 impact is happening on a daily basis, but through chronic disease and other, less high-profile conditions, and so we have an opportunity to ensure that actually the incredibly rapid, sophisticated, joined up approaches to evidence synthesis and implementation is business as usual for healthcare more generally, and not just a one-off in relation to the pandemic. That's the real opportunity.
Thanks, Jonathan. And there have been some questions around chronic disease, so I'll go to those that question now. But first, John, is there any additional comment?
Well, what I was thinking about, I was struck. I've been struck in many conversations with colleagues in Australia that it doesn't feel like you have the same sense of urgency and the same perception that we're at a critical juncture in different countries around the world in terms of needing to systematize what's going well and fill gaps. And that's both to the high-level policymakers and some of what I was pointing to, the central agencies, the routine decision-making processes, the standards and procedures for evidence. It's about them, but it's also about citizens. And we've been so struck by our citizen partners just saying, we need a better system that gives us in plain language an evolving sense of what we know. So when I was reading Kate and Dimiti's comments, I was thinking, gosh, I mean, those conversations come up here, but did COVID accelerate our move to rapid learning health systems? No, in fact, it slowed us down a bit. And I hope that as we move back into a bit more steady state, we'll get back to trying to figure out how do we build a rapid learning health system that it can accommodate the types of feedback that Kate called for, that can accommodate the types of rapid support for implementation that Dimiti noted was absent. But the burning platform for me is with this evidence support system that helps all of us to access the best evidence when we need it. And that shouldn't be limited to COVID-19. So my questions to the Australians on the line, not just Jonathan and Sarah or you, Joe, but were our experiences over the last 27 months so profoundly different in many other countries versus Australia that we have a different sense of where we are and the urgency to act on the lessons? Because I don't hear the urgency in Australia. I don't hear the talk about this being a critical juncture in the ways that I hear in so many other conversations with colleagues in other countries. So if anybody has any reactions to that, I'd love to hear about it. We're just, as I mentioned before, about to start meetings with Greg Johnson and others about the rapid jurisdictional assessment. And I know you're doing many things well, but no country is perfect. There's got to be opportunities for improvement. Where's the sense of urgency to make 2022 the year? The Biden administration has named this the year of evidence for action. Where is that momentum in Australia?
It's a very provocative question, John. So any response from our Australian panelists?
Other than I would agree. I think there are conversations. I mean, John, are you just talking about the NCDs more broadly and the urgency around those? Because I don't think we've got that sense of urgency around there. I think we've got still momentum in the evidence and translation space. I think Jonathan's example is a really good example of an NCD which does balance the citizen input with the data and other evidence-driven approaches. So I think that there are pockets of that. There's a potential, of course, if we end up, so there's conversations here about having a national CDC, and one hopes it's CDC and prevention, like the US one. And so perhaps that was a commitment in the federal election that we've just had here with a change of government. So maybe there's an opportunity here to actually drive, firstly, continue to drive the evidence one, because I think we have momentum, think we can keep going in that space, not just in New South Wales, but elsewhere. There's strong momentum in the data and analytics space, but we do need more. We haven't got a lot in the citizen space, but perhaps with the new preventive health strategy and the establishment of an Australian CDC and prevention, which I'm going to keep putting at the end of it, that perhaps that might help galvanise and drive the urgency that you're talking about. So I think we've got opportunities. We're not quite there yet, but perhaps this is the year to see that change. And let's do a tax year in Australia. That's July to next year. So in the next financial year, I think we have real opportunities. Would you agree, Jonathan?
Yes. So I mean, so it depends on whether there's a corporate view that we have a problem which needs to be fixed. COVID clearly demonstrated that was a problem that needs to be fixed. I don't have a strong sense, and have been involved with the Living Evidence Consortium and working with government. I don't have a sense at the moment that there is a strong view amongst policymakers, research, clinician, health departments that we have a serious problem that needs to be fixed. Would be my observation. Now, maybe with changes in the economy which are occurring, and the recognition that we are not in a position to pay for every healthcare, innovation, drug, genetic, etc. That might be a major driver that we actually have to look at our healthcare financing processes more. There certainly are moves by industry to say that the current approach with respect to HTA is problematic. I'm not sure that I agree with them in terms of the problems that need to be fixed, but I share your views. I share your views, John.
Just want
could
to
I
add
just
one more
ask?
thing.
Oh, yeah. Go ahead.
John, I was just going to say, you talked about your Treasury Department sort of not requiring evidence. So our Treasury Department does require evidence, but it's perhaps not the evidence or the breadth of evidence that we in a health system would actually like to see. It's purely CBA. It's not even other forms of economic evidence, but you literally, and that's very hard to apply in the preventive space for a whole range of reasons. I'm not a health economist, so I won't get into it. So, but they do have evidence guidelines. We have an evidence bank, etc., with a strong economic focus, which has its strengths and weaknesses when it comes to prevention. I just wanted to throw that into the mix, but I would agree with Jonathan that we're coming to a very tight fiscal environment that's going to have to drive some decisions. I know Angela Todd's comment about the flag.
And certainly that those sort of requirements around evidence evaluation also exist in other states, but I think we'd probably find that there's some differences in those expectations as well. But just on the NCD focus as well, so Henry Brodati in the chat has said about the focus on NCDs, and that infectious diseases and COVID's like the poster child for public health. And I think that's sort of shown us that's the same as it ever was in some sense, in terms of there's always been certainly in the public imagination, a stronger focus on communicable diseases. But that so his question or comment really is that it is more difficult for NCDs, except where there's a procedure, so something like a transplant or a joint replacement. And so, how can we capitalise on the experiences of COVID, which is in a particular space in public health, and be able to build that sense of urgency in terms of action, which also then relates to the question about building a sense of urgency in the evidence systems to be able to support that. So I don't know. I mean, I think we have talked about that, and it's perhaps, and then Henry Brodati then goes on to ask are there other countries where we can learn from in terms of the NCD prevention, I'm presuming, and he suggested say the Scandinavian countries. So comments from that from any of the panelists around how we leverage that interest, and there's certainly a lot of community interest and understanding and awareness of public health now in a way that hadn't been in the past. And so what are our opportunities there?
So a couple of quick comments. One is, I guess I'm a little bit surprised by how focused on NCDs the conversation is, and perhaps just a reflection of who's on the call. But when we did the analysis for Canada, we went to the number 2 in Cabinet Office, Deputy Secretary, Deputy Minister level, so our top person, and presented. He said 3 things, and I said, maybe we've misunderstood, maybe stuff is happening we're not aware of. He said 3 things. One was you're right on the analysis about the strengths and the gaps. Second, I'd really like to pull together champions from across government to talk about how we up our game. I'm convinced we can do much better, and you have pointed in many of those directions. And the third and most powerful thing that he said was, when you speak to people in other parts of government, please tell them that we are interested in change. And it feels like we're in such a specific box with NCDs. But yet, I don't know, Sarah, how you get all of the changes that would have to happen if we're going to make a big difference on NCD prevention if you can't get to Cabinet and to Finance and to Treasury Board and have them value evidence and require evidence in these different formats that go in, and that they are required to up their game. And maybe in Australia, science advisors don't play as prominent a role as they play in many other countries, but they are often a countervailing power to the use of robust evidence. And while you were exemplary with your living COVID panel for clinical management, I understood that a lot of the expert panels happening in Australia were a bit more on other issues, a bit more like the traditional panels. So do you have any reactions to this need to go hard at what's going well and where the opportunities are outside health, but in the central parts of government that are such important drivers of what gets decided at the end of the day?
Again, I can probably only touch on it because part of, I think some of this work is being done elsewhere. Just say that we're working on Treasury. We're working really hard on Treasury about changing what they accept as levels of evidence. And we are, and that's a huge piece of work. And we're already seeing changes to their guidelines. We're having those conversations. We actually think that we'll get them to change. So I think it's one of those behind the scene battles, which we don't get any sort of benefit from up front, but I think we'll get there in the end in terms of understanding what evidence is required. There's lots of activity though happening across government in the in the prevention space and the risk factor prevention space. There's active transport pieces of work and evaluations that we're supporting where health is not the lead. And we're also trying to get changes to the planning guidelines, which better support that active transport. And so I think there is a lot of work happening. Again, I'm not probably the right person to talk about that, but I know that it's there. In terms of how, there's work happening that's being led by TAPSI about talking about the benefits of prevention. This is the same concept that one needs to apply in the NCD space. We really need to communicate the why. And yes, financially is actually a really good reason. We know from a human services perspective, it's not the only reason. It's not actually what really matters, but it's what gets the interest of other agencies, not just Treasury, but those central agencies. So understanding the value of prevention and working hard with our key partners in education and transport is where our main works are in planning. We are seeing some changes happening. So I think there is lots happening in that space. We tend to not call it health. We talk more about because they just think health should do health. So we should we are working behind those scenes to actually make those things happening. So I think it's not a lot of space, not often seen, but you'll see changes coming, I think, in a few years.
Okay, so I'm going to have to draw the conversation to a close, but I would just like to acknowledge the comment that Dimity's made in relation to the role of New South Wales Health in terms of incorporating general practice into decision making, and also her comment later about that the College of General Practitioners set up a community of practice as well, which sort of helped to facilitate that. And there was also a question in relation to the building of capacity of people who'd been seconded into the health department and whether there'd been some impacts of that. But unfortunately, we've run out of time for more detailed conversation. So what I would like to do is to thank everybody, well, certainly to thank our panel. I think it's been a very interesting session, but also I think John has challenged us to think a little bit more critically and to look a little bit more forensically, I suppose, about what's working well and what's not, because I think that there is a collective sense of we've done really well, and I think that that's exactly the case, but that there's also things that we can learn for what didn't work well, and in fact what the next step is as well. So what I need to do as part of my role is to just let you know that the Sax Institute is having its Research Action Awards. Applications are open, so please look at that and circulate that to your friends and professional community. And the other thing I would like to say, of course, is that the Sax has a very strong role, particularly in New South Wales, but more and more in a national sense as well, about being a research organisation that supports the mobilisation and use of evidence, and which is a really important part of the research and policy infrastructure. And similarly, the Australian Partnership Prevention Centre as well has a similar kind of role as well, but sort of more in the non-communicable disease space. But I do think that, just in closing, that there's a lot of opportunity to reflect and to think about what that next stage in evidence systems is. And certainly today's conversation has given us some good pointers in the places that we might look to address those things. So please join with me in thanking John Lavis, Jonathan Craig and Sarah Thackway, and I thank everybody for their participation today. Thanks, everybody.
Thanks, Joe. Thanks,
Bye-bye.
Jonathan and Sarah. See you soon.